Hi, it's Rick Bukata here for part two of Pearls from the Recent Medical Literature. My cohorts are uh, Jan Schoenberger, who she's at USC. They have 80 house staff there. It's hard to believe. It's like a little city in their emergency department. Anyway, Jan was a program director for about 8 years, moved up to the ladder, vice chair of operations and education now. She is boarded in palliative medicine, which I have a great deal of respect for you, Jan, for being one of the handful of doctors that I know that have thought that that was an important thing to do. A couple of years ago, Jan got the CalASIP Education Award. Ken Milne, those of you who get the Skeptic's Guide to Emergency Medicine, which has to be, better part of the world. Ken is the founder and the sage of that program. Every week coming out with a paper. It's like, Ken, how many papers are you up to now? Like three or 400?
Yeah, about 400.
Oh my. Well, anyway, Ken is up in Canada, Toronto, where they're having actually a nasty spell of COVID going on. He, not in addition to being the creator of the Skeptic's Guide, he was the chief of staff at his community hospital, and he was the director of the emergency department, but now he's really doesn't have any titles, I guess. Just a nice guy. And
I'm just a frontline community doctor. Love it. Love it.
That's exactly
especially
right.
during COVID. I'm absolutely loving just working clinically as opposed to all the administrative meetings.
You are a frontline community doctor, and I have the greatest respect for those folks. All right, let's go. We're going to start with some papers. We thought that they were provocative, interesting, controversial, and I think the first one coming up is in that genre.
Yeah, I've got the first one, and this is part two. This is the session part two. If you missed part one, because part two, it's going to be better. It's like a sequel that is better. It's like Terminator 2, The Godfather Part 2, Return of the Jedi. I mean, or I guess it was The Empire Strikes Back was the second one. But this is going to be a good group of papers. So we left off the first session for those who weren't there. I can't believe you weren't there. But the first session talking about urgent care clinics. This next paper looks at freestanding EDs. Okay, freestanding, not free EDs. They would be very popular, wouldn't they? But These are freestanding emergency department. What a concept. And the concern that there's been around these freestanding EDs is they're really not located in the areas of need, like rural hospitals. You know how they talk about food deserts? Well, this is like care deserts, right? So they're not located in rural areas or the underserviced areas, but they're really close to other emergency departments. And so this Medical Payment Advisory Committee proposed decreasing the reimbursement rate to freestanding EDs close to hospital-based EDs. And the distance, I don't know why they came up with it, was set at 6 miles. And this study used some fancy mapping tools to figure out where 5,000 emergency departments were, and 600 of them were considered freestanding. And no surprise, a very small number, and what I mean by small number is like a single percent, were located in rural areas, with a super majority, 3/4, were within 6 miles of a hospital-based ED. Now, it was voted yes that they should decrease these payments, but I looked into this before we recorded, and I didn't find that these recommendations had ever been implemented to decrease payments to see if they could significantly impact these freestanding emergency departments.
Jan?
Well, yeah, I mean, we knew this. We've had other papers about freestanding EDs. We know that they're generally located in places with good payer mixes, no surprise, and that they are often not too far from another ED. And so there's been a lot of controversy about freestanding EDs. In fact, I remember being at a dinner at ASAP years ago with Billy Milne and some people who worked at some freestanding EDs, and it was quite a heated argument about the value of freestanding EDs and what they offer. And I think that this, we don't need to get into all that with this paper, but it's an interesting paper that really maps out where they are. And I don't know much about the payment part. I don't work at a freestanding ED. So Rick, do you know anything about that? And maybe that goes into number 19, because we do talk about that a bit.
Yeah, well, the idea here is that they basically are getting the low-hanging fruit from the emergency departments, and this is kind of concierge emergency medicine. Now, I don't want to get into whether I'm a fan of this or not, but I think my my point of view will become pretty evident pretty quickly.
Would they be doing a follow-up paper where they don't just map how close it is to an existing emergency department within a hospital, but if it's in the burbs, is there a distance to a Trader Joe that would be the metric or something like that?
Gelson's
It's Trader Joe's, Ken. It's Trader Joe's.
What did I call it?
Trader Joe.
Oh, Joe's. Sorry.
Yeah.
Yeah, exactly. Actually, that place was started here in South Pasadena, right around where we live.
Right beside the freestanding ED.
They don't allow them in California.
They don't do that in California.
Yeah, we didn't.
Got some restrictions.
That's right. And so every state's a little bit different about what they allow. And, just if the devil's advocate argument, if you work at a freestanding ED, is that, it's like you get ED care without the wait. It's very convenient. It's very patient centered. I mean, those are the arguments that I really heard passionately from people who work at these freestanding EDs. They help to decompress the real busy ED that we have, that's down the street kind of thing. So, there is some argument there.
And this is all foreign to me because we don't have this here. So,
yeah.
Well, conceptually, it might be a good idea. In the middle of nowhere out there, where you have a lot of nowhere in Canada, where you stick an ER that has, a CT scanner and a little bit more than would normally be in urgent care.
Right.
In Saskatchewan or whatever it is out there that has no people, no nothing, no trees, no nothing out there. You might want to put one of these out there. All right. So this basically says that the urgent care centers are basically on top of the emergency departments.
Freestanding EDs, not urgent care centers.
Freestanding.
Differentiate.
Oh, that was a mistake. All right. Number 19 is from Kaiser Health News. Now, that may not be the New England Journal, but I think it has an interesting story. This title of the story is Colorado will pay hospitals to close expensive freestanding ERs. This basically looked at Colorado. There's 44 freestanding emergency departments in most of them set in affluent suburban communities. 34 of them are owned by hospitals. The state of Colorado determined that most have low acuity patients, just like urgent care centers, mostly non-emergency care that could and should be treated at urgent care centers or outpatient centers. And they basically say, we don't want to pay emergency department prices for urgent care patients, and we're going to pay you to close these things down. The billing they talked about in their article was 10 times higher than an urgent care. But actually, I've seen examples where it's 22 times higher to get the same care in the urgent freestanding versus the emergency department. So the state of Colorado basically is going to say, we want you to convert these into mental health centers, primary care centers, anything but a freestanding emergency department. They surveyed the people that owns these things, and they said, no, we're not shutting these things down. We're in it for the long haul. But this is a state that basically says we cannot afford to pay people to go for urgent care visits for the freestanding ER prices.
And this is one of those papers where I really wish we were live at ACEP so we could actually hear from somebody who lives in Colorado as to whether or not this is happening. Because I couldn't tell from an internet search, whether or not this is actually happening. And this was just a few months ago. It's not that long ago. So perhaps this is kind of in the works sort of thing. And I'm curious to know what, people who do work in these freestanding EDs, how they feel about it, what they're going to do about it, how this proceeds, because it's an interesting thing that they're, that the state is basically saying, I read the same way, Rick, turn it into a psych place. We need mental health. We'd much be better off turning this into a mental health facility or a primary care facility. And I'm wondering if there's, any resistance to it. Now, how much money are they paying? I mean, what is the incentive to do this? Is it worth it? Probably not if you work in one of these freestanding ERs,
Yeah, I don't think there's a lot of money in mental health and primary care.
No, that's
unfortunately,
true.
Yeah.
So
all right. So yeah, the next one, we're going to kind of switch topics here and talk about stroke and TIA. And so this next paper, number 20, is called Ticagrelor and Aspirin, or Aspirin Alone, in acute ischemic stroke, or TIA, and it was in the New England Journal. And so it's a little bit, I don't know if it's really an ED paper, but it's of interest to us because we do see people with these conditions. So it's a big trial. This is called the Thales trial. It's an industry-sponsored trial by the maker of ticagrelor. And, the question is whether when you have somebody who's got one of these strokes, are they going to, we know that most of them go on aspirin, but if you add this other antiplatelet agent, ticagrelor, to it, do they do better? So it's 11,000 people who had strokes. They were either ischemic strokes, which was the vast majority of the patients, or a high-risk TIA, which meant that your score on the ABCD2 thing was high, but it was mostly strokes, like 90% of them. And they got 30 days of either ticagrelor plus aspirin or placebo plus aspirin. And they looked at an outcome that was stroke or death within 30 days. So there's about, 5,500 patients in each group. And it looks like it slightly reduced the strokes in terms of incidence of stroke, but not really disability. That didn't really differ. And there was 4 times as much bleeding in the group that got both agents, not surprisingly. So,
and when you look at basically the people who got this drug, what was the number needed to treat? The number needed to treat was 90. So 90 people had to get some benefit, 90 people, but the bleeding risk may have been, higher than 1 in 90 in terms of that outcome. So I'm not so sure that we got a blockbuster here.
Agreed.
Yeah, and also the 30 days. For either both benefit and potential harm, if you're on a dual platelet anti-therapy or DAPT, you're going to be on it for weeks, months, years. And so that risk of bleeding becomes more of a concern. And the other thing is, we have much stronger evidence in the cardiac literature for this. And so how I view this usually with patients is saying, hey, there's a few less strokes, a few more bleeds, and there's no difference in neurologic outcome. But if they have a strong cardiac history, I can justify doing dual antiplatelet therapy because of their cardiac. But if it's just for stroke prevention, I usually stick with monotherapy.
Oh, can I go back to the just briefly to the freestanding ER? If any of you in the audience have anything to say about this topic, I'm going to give you Jan's email address.
I was saying what the
she
pros
was the supportive
are.
one. Yes, she was devil's advocate.
I just don't want them coming to me. Shall we move on? Now we're getting into a kind of a cool topic, I think, here about whether you should give thrombolysis to a person who's going to have their clot sucked out.
Yeah, so this is mine. This is number 21, and this is the effect of IV tenecteplase dose on cerebral reperfusion before thrombectomy in patients with large vessel occlusion, ischemic stroke. And thrombolysis is routinely used before EVT, but in Australia, they tend to use a lot more of TNK or tenecteplase as opposed to alteplase. And this was to see what dose of TNK would be best to use before they're going to do the thrombectomy. So this is just not thrombolysis alone. And they looked at 0.4 versus 0.25 milligrams per kilogram. So it was a dosing study. They were short 1 dose, in my opinion. Jan, what dose would I have used?
Exactly.
0.
It was a nice round number, yes. So they had 300 patients. Yeah,
it's really easy to give that dose. Yeah.
0. So they had 300 patients in this open label trial, and they found no statistical difference between the 2 doses. Now, the primary outcome was reperfusion. It wasn't neurologic outcome. And yes, reperfusion is associated with neurologic outcome, but there's more involved than just reperfusion. Because if you don't have survival brain, if you don't have good brain tissue, flooding it with blood flow doesn't cause a Lazarus effect and the brain to wake up or something like that. Their secondary outcomes were good neuro outcome, and they were about 55% in both groups. So there was no difference in that with regards to good neuro outcome. But with the higher dose, you got more symptomatic intracranial hemorrhage at the higher dose. So, yeah.
Yeah, great. Bonus. Extra bleeding.
this paper is leading up to.
Yeah, that's why I'm not going to spill the candy dish here.
Right. Yeah, exactly. And you did kind of spill it in advance with the zero dose thing. That's for sure. Yeah. It was like, there it was, just like this. We set it up for him and they hit that ball right over the net kind of thing. All right. So 20.
Steal your thunder.
And 22. Let me read the title properly here. Endovascular thrombectomy with or without intravenous alteplase in acute stroke. New England Journal of Medicine. Everybody bow your head, please. It was a multi-centered, randomized, non-inferiority trial in China where they compared endovascular thrombectomy with or without alteplase within 4.5 hours of large vessel occlusion. This is a large study. 656 patients were enrolled. And bottom line is that there was no advantage to giving thrombolysis before taking out the clot in these people. And yet I believe most places are giving this is religiously. You're getting thrombolysis before you get your clot removed. And one of our hospital's neurosurgeons who's in charge of the stroke center said, a couple of days ago, we got that stuff in 11 minutes. And it was like, geez, do we need to put that stuff in 11 minutes if you're going to suck out the clot? Because we are a stroke center at the hospital that I'm affiliated with now. So there are people are saying, do we need to do this? And this paper basically said, didn't get any better outcomes here. And is that the only one like that? Number 23?
No, it is not the only one like that. So number 23 comes along and sort of, hits the ball again and says same thing here. So this is a JAMA paper from China looking at a very similar question. This is the DEVIT trial. And they had 33 different centers and they're comparing the thrombectomy alone to the alteplase then thrombectomy question. And they planned this trial for over 900 subjects, but after enrolling just over 230, they stopped it, which just drives us wild, right, Ken? Just drives us crazy.
Don't trigger me. We're already talking about like thrombolysis here.
I know. And so they said, well, it looks good now, so let's just stop right here because boy, that thrombectomy alone group looks pretty good. And so they just stopped it, which is so frustrating. But they concluded that thrombectomy alone without the alteplase was safe and effective as the combo. So, interesting.
They said it was non-inferior.
Non-inferior, right.
Pedantic about it. It was non-inferior. Right. It wasn't equivalent. It wasn't superior. It was just non-inferior.
Yeah. And so this was like, I think this was the third trial that had come out saying that this looks the same. And so, I mean, it just sort of is pushing the envelope saying, okay, when are you going to change the guidelines?
Yeah. And that's number 24. This is the third trial. And, ironically enough, it's called the SKIP trial. And I don't know, maybe we should skip this one because it came to the same conclusion. This was Suzuki et al. The difference in this trial was in Japan, they use 0.6 milligrams per kilogram of IV TPA. And I'm not going to go into the details of why, but they found no statistical difference in mortality or symptomatic intracranial hemorrhage. But they failed to demonstrate non-inferiority. So the other trials did demonstrate non-inferiority. This trial did not. I know it's a double negative, demonstrate non-inferiority because the lower end of the 95% confidence interval breached their pre-specified level. But the confidence intervals are really wide. But I've got Rick hot off the press. Ready for this?
I am.
This is not in our abstract set. But in August, I think it was August 21st, a systematic review and meta-analysis of the three trials we just talked about, Yang, Z, and Suzuki, were combined. Those 1,000 patients were put into the meat grinder, and they spit out those 1,000 patients to find no statistical difference in the primary outcome, no statistical difference in all-cause mortality, and less bleeding with EVT alone. And so my conclusion from these three randomized control trials is that there doesn't appear to be any high quality evidence to support pre-treating these people with TPA prior to EVT, if EVT is, readily available.
Is that the standard of care in our country?
To give it first, yes.
Yeah, Jan, what do you
It
think?
is. Yes, it is. That's the way that we do it, because that's formally what the guidelines still say, is that you should give the IVTPA, before you do the thrombectomy, or in addition to. So, I think that there are probably some people based on this trial that are maybe not doing that, but it's really in concert with your neurologist how you make decisions about what you're doing.
Well, that's true, but these are the same papers hopefully that they would read. And
yeah, for sure. So there's some that are changing practice, right? But when you have these established guidelines that come out from the AHA or the American Stroke Association, it's always really hard not to do what they say. And even when like this is like, go back to the epi example that we talked about in part 1. It's hard to stop doing what's sort of in those guidelines. But I think we're all just sort of holding our breath and saying, just change the guidelines, then we can do the right thing.
Well, plus this is a drug that can harm us. I mean, it's like keep your fingers crossed when you push that stuff in, kind of thing. And so I put these papers in here basically to stir the pot, because this is going against everything that is done in this country, and yet.
But Rick, I think it's heading towards the same way that we did with STEMIs and cath labs, right? I mean, when I first started, we were dripping and shipping, right? We would thrombolyze with TPA and then TNK, it evolved to, and then ship them off for their cath. And now they find that, this facilitated PCI is really not the way to go. And there's increasing bleeding, increasing harm. And so you just, if you're within a certain distance or you have one in your shop, you just send them to the cath lab, right?
Yeah.
And so,
and now, these days with the imaging, we get imaging so fast, and you see what you're dealing with. And if you're right, if you're doing the thrombectomy right where you are, I mean, you just go do it.
You've got a large vessel occlusion with a small core size, a salvageable penumbrum. Why are you messing around with giving, some thrombolytics when you could just take them up?
Well, the next extension of this is, what are you going to do when your hospital doesn't have this thrombectomy equipment, but you have to ship this person now? Now do you give them the
that's another question, isn't it? Yeah, that's another question.
Yes, it is.
And that's why I qualified it that's why I qualified it when I said, if EVT is readily available, right? Because that's what we can conclude from the data we have.
25, is lumbar puncture required to rule out subarachnoid hemorrhage in ED patients with a headache and normal brain CT more than 6 hours after onset? Well, there's the word, 6 hours there. Okay, so these folks did a literature review triggered by a case that they present. And basically they said it was 2 cohort studies and 1 case control study was the totality of what they were able to look at on this important question. They calculated the harms and benefits of performing a lumbar puncture in patients with a negative CT, and note that 1% of patients who have a negative CT, according to them, will have a subarachnoid hemorrhage. So, and then there's the issue about, well, how many lumbar punctures are you going to have to do to find that person? Well, according to this, you're going to have to do 100, or I think it is 100 is the answer. And so they say it is reasonable, you're going to like this, Ken, to forego or perform lumbar puncture in patients with a negative CT based on shared decision making. There you go, Ken.
Well, we know in the under 6 hour group, it's the number needed to tap, the NNTP, the number needed to tap is 250. So they're at higher risk when you get out past 6 hours because the CT is not as reliable.
Yes.
And so this all comes down to a Bayesian approach. And that's what they talked about in this paper, about using a Bayesian approach. And you look at your pre-test probability. Do I really think this person has a subarachnoid hemorrhage? And then calculate your post-test probability and look at what's the test threshold. And in this case, if your the test threshold is 1%. So if you have less than 1% concern that this is going to be a subarachnoid hemorrhage, don't get the LP, they suggest. If it's greater, if you think it's greater than 1%, then they say, yeah, you should go ahead and get the LP.
And try to make it non-traumatic. if possible, because they spend a lot of time talking about how, the fact that LPs, when they come back traumatic, it really affects the test characteristics, and then you're in this quandary, and so if you throw those numbers into it, it makes it even less valuable of a test. And fuzzy, you can do you can do a lot of statistical talking yourself out of it. But I think that point, if you really still think that this person in front of you has a subarachnoid hemorrhage based on the story and the person in front of you, you still need to do the LP. So
absolutely.
And this paper doesn't really get into the whole like LP versus CTA, which is a whole nother, debate, but right. They need some extra workup.
Okay. Moving on. 26.
26 is about the HINTS exam. So the title is, Can Emergency Physicians Accurately Rule Out a Central Cause of Vertigo Using the HINTS Exam? A systematic review and meta-analysis from Academic Emergency Medicine. Now, the HINTS exam got really popular when it first came out primarily because patients with dizziness, just drive us crazy. It's probably a lot of people's least favorite chief complaint. And so if you can give me some exam, give me something that I can do, I would embrace it. And so the HINTS exam got really popular. I never found myself very able to do the HINTS exam with a lot of gusto and a lot of accuracy, I felt. So a lot of these papers that are kind of kicking the HINTS exam in the shins, I'm sort of welcoming. But anyway, this is the HINTS exam. The HINTS exam was developed to rule out central causes of vertigo. They found 5 studies that were applicable to their question. Only 2 of those, by the way, were in the United States. And most of these studies actually were on inpatients, with some ED patients kind of thrown in. And all these patients got imaging to, confirm what they had. So it's a particular population of patients that were studied when they asked this question about the HINTS exam. And it turns out, not surprisingly, we are not as good at this as neurologists are. And so our sensitivity to rule out or rule in stroke is just not there. It doesn't reach a really, really good threshold, at least not the threshold that the neurologist set. So, the HINTS exam, we're going to talk about in the next paper too, but, it's an exam that you have to use appropriately in the right patient who has an acute vestibular syndrome going on. It can't be used in the patient who's got dizziness sometimes, or sort of non-specific dizziness. And so, there's a question of whether we use it in the right patients as well. But I'm not a big fan, so I kind of like this paper.
This is my attempt to get rid of the HINTS exam.
Yeah. Kick it in the shins.
I want out of here. I like this next paper because it says we're trying to do this test on people who don't even qualify for the test.
Well, I have to agree with Jan. When it first came out, there was a lot of enthusiasm for it. And part of the enthusiasm that I had was that in certain hands, not these hands, but in certain hands, I believe it was Dr. Newman Toker, who is the neurologist, right, who runs a dizzy clinic. This is what he does all the time.
Oh, God forbid. Please don't make me work in a dizzy clinic.
He was more accurate than an MRI, right? And so I like that. I like a physical exam that has better diagnostic accuracy than this huge, big magnet. That's why I liked it. Okay. Not because of the dizziness stuff, but I really like the physical exam could supersede, some modern technology of laying on the hands. But it just wasn't my hands. So it never worked out well for me. So I've got number 27, and this is the diagnostic accuracy of the HINTS exam in an emergency department and a retrospective chart review. And I have to first say that I have some conflicts of interest. I know a number of these authors, and some of the authors on the previous paper, a couple of them are the same authors on this paper, and they happen to be a couple, a wife and husband. So this was a single center Canadian academic center, and they did a chart review of 2,300 dizzy patients, and 1 in 5 had a HINTS exam documented. So obviously all dizzy patients are not getting the HINTS exam in the emergency department. The vast majority, 97%, did not actually have an acute vestibular syndrome, and only about a third had an acute vestibular syndrome, had a good HINTS exam documented in the first place. So we don't do a good job of this, but we can. And there's a really an amazing physician. He's in Ottawa. His name's Dr. Peter Johns. And if you go to YouTube and you put Peter Johns, Dr. Peter Johns, or something with dizziness, he has this whole series to make us better, not just necessarily the HINTS exam, but making us more welcoming of the dizzy patient and embracing it and just leaning into it. Well, I guess with dizzy patients, you might be leaning this way or you might be leaning this way, but lean into it and get really good at examining patients with dizziness.
Yes, Ken, I'm glad you brought him up because I've talked to him and he's of the view that this is a good exam, but you have to do it in patients who qualify. And we're doing in most patients who are getting it really don't qualify for it to being done. And he does have these videos, these YouTube
They're really
videos.
good.
If you would like to take the dizzy patient a little bit more seriously, we Peter Johns. 28, it gets to a simpler topic. I did want to blow up the HINTS exam. I did my best. There was only 2 papers, but let's get rid of it. Get that MRI. Even the MRI is not very good until like it's a day or 2 later. So it's like,
yeah, it's not as great as well. It's not great too with this diagnostic accuracy. And the thing with Peter Johns and the HINTS exam and all of those types of things, using the HINTS exam, it's a tool, right? And if you're ordering a D-dimer on everybody, it becomes a useless test. So you got to know which patient does the HINTS exam apply to, and then how to interpret it. It's just like the D-dimer, and that's why we hate the D-dimer, I think, is because everybody just uses it for everyone.
Well, I think one of the problems with the HINTS exam is there is a technical skill required, and we never know whether we have achieved it satisfactorily.
But emergency physicians are really good at picking up very complex procedures and very good at getting mastery.
They weren't so good in
those procedures.
They weren't so good in the prior paper,
but that's training. That's training, right? So watch the videos. I'm supporting it. I'm not saying I'm an expert. I'm not great at it, but I'm willing to try to be better at it.
If you don't want to do the HINTS exam, here's good 2 papers for you. 28. I thought this is a cool paper. Comparison of IV ketorolac at 3 doses for treating renal colic in the emergency department, a non-inferiority randomized controlled trial. It's from Iran, 3 academic emergency departments, and they had 3 groups of 55 patients, and they got 10, 20, 30 milligrams for their suspected stone with morphine rescue if needed. And they looked at what happened at the end of an hour, and pain scores dropped dramatically in all groups from 80 to 10. No difference between groups for any measure, including morphine rescue or numerical pain scores. The conclusion, 10, 20, and 30 milligrams provide the similar analgesia in renal colic. And my question is, what about 5 milligrams? What about 2.5? It's like, this goes along with this idea that there's a ceiling for analgesia with the NSAIDs, and like for ibuprofen, we think it's 400 milligrams. It appears like the ceiling is a lot less than 30, 20, and in fact, the smallest you're basically going to give is 10. But so this is consistent with that idea. So that more is not necessarily better. More is just more, and in this case, maybe harmful.
There was a paper a few years ago that said a very similar thing, that a lower dose was just as good as a higher dose. And, these papers, they don't follow people out to say whether or not it affects the side effect profile, that if less is better and maybe you have less GI bleeding or less renal effect, et cetera. We don't know that, but we would assume that that's probably true. So if the pain efficacy is the same, then decrease the amount of exposure you have to these drugs that have these side effects.
Yeah, so this is, I think you're referring to Sergei Motov, who's the pain guru out of New York. Yeah. And so he did that ketorolac study looking at acute painful conditions in Annals of Emergency Medicine 2016, looking at the 10, 15, and 30. And there just isn't the same linear response as there is with opioids. There's a ceiling effect. And if there's no additional benefit, it doesn't matter. There can only be potential increased harm. But I was talking about this with, again, it was Mike Heller again, Mike Heller, going, why do it? Why do it? And he goes, well, you give more drug, with the half-life, you'll get less frequent dosing, so it'll last longer. And so I guess that is a potential benefit. Instead of taking something every 6 hours, you could be taking it every 8 hours. Maybe that makes a difference for the patient, but I don't know.
Yeah, well, we don't really know what happens after the hour, right? If it lasts longer. I hear what you're saying. Yep.
Yeah. Right. but I conceptually, you don't like the idea of, well, we're going to give you twice or three times more than you need in the hope that it lasts for another hour, 2, 3, 4, 5, which we don't know the answer to that, frankly. So
well, the pharma, I think that they will know that it will last longer, whether that threshold and drops and stuff like that, but it will last longer because it metabolizes at a fairly consistent rate. So
31.
29.
29.
Oh, I'm sorry. I'm sorry.
Okay.
I got ahead of myself here.
And 29.
And 29. This is more about pain medicine, and this is ibuprofen plus acetaminophen versus ibuprofen alone for acute low back pain. And this is an ED-based study. And so the question is, is ibuprofen by itself, or, throw in a little bit of acetaminophen? Is that better to add it to it? Let's see. So they did a randomized placebo-controlled study. They had people take 600 milligrams. That's the dose they chose. 600 milligrams of ibuprofen every 6 hours, plus either acetaminophen or placebo. Now, their acetaminophen dosing, they started with 500, and if that wasn't helping, they could take 1,000 of a gram. So they had some variability in terms of how much acetaminophen the patients got, which is probably one of the problems with the trial. They had sort of a range of dosing, and then they just saw what happened basically at 1 week, looking at one of these scales about their quality of life, their function, etc. They also looked at some secondary outcomes, and it seemed like adding the acetaminophen to the ibuprofen didn't improve things at a week. It didn't matter. It kind of seems like with low back pain, it's kind of like no matter what you do, nothing matters. I mean, that's another thing here. That's adding the acetaminophen, although a lot of us recommend it, didn't seem to matter to the ibuprofen alone.
It seems like a kind of a puny dose of acetaminophen.
Well, that's the thing. We don't know how many people took the gram versus how many people took the 500 milligrams, which is, we don't know.
Or even 1,500 milligrams. I mean,
yeah.
they have made this drug more toxic now. The therapeutic dose used to be 4 grams a day. Now they moved it down to 3 grams a day, because they think that there's going to be a really small subset who may get some liver problems out of it. You wonder whether that is kind of hurting all the other people who used to take 4 grams a day for pain, because it's got to be safer than the NSAIDs if it works for you.
I have an answer for that, though.
What is the answer, doctor?
It doesn't matter. I mean, effectively treating back pain is a challenge, and the patients aren't challenging. I want to be clear about that. It's not the patient that's a challenge. It's the medical condition that they have. And they've tried so many different pharmaceutical treatments for low back pain. And they've done large studies on acetaminophen alone at appropriate doses, and it found, meh. They tried muscle relaxants, meh. They've tried steroids, meh. They've tried benzos, meh. They've tried NSAIDs, meh. So this was a paper saying, okay, what about the combo? Is there some synergy there? Meh.
Yeah.
Right. But I mean, we can't just dump on us as physicians, because when you look at the non-pharmacological therapies, again, meh. CBT, mindfulness, chiropractic, physiotherapy, massage therapy, acupuncture, nothing has really good evidence except for the next paper, opioids.
There's one little tidbit from this paper I forgot to mention that I want to mention, which is that at a week, it was like 28% of the patients, almost a third, still had moderate to severe pain at a week.
Set expectations.
And so, exactly, which is, so there's a little nugget in there, which is don't, remind people, tell them how long this is going to, a third of people at a week will still have moderate to severe pain. And so that's important to just point out again, because it's time that really does do something for back pain, right? That's the one thing that probably works, which is tincture of time.
This too shall pass. But that gets to the Rick Bukata, education component of, if somebody says, oh, you've got this really bad bronchitis, i.e. chest cold,
right.
you better see your doctor again if you're not better in a week. No, like the median time is 3 weeks, right, Rick? And so you are always hammering away going, don't set patients up for failure. Don't set them up for repeat visits that they'll be costly and they don't need. Don't tell them they're going to be better in a week and seek care if they're not. This is the same with back pain. Telling people, oh, if it's not better in 3 to 7 days, you better seek care. Most people won't be better in 3 to 7 days.
I sometimes think it's a little, frankly, unethical that you advise a person to be seen by another provider when in the time frame that is unlikely to be significantly better, and yet they have to go to the doctors, take off, get a ride, all of these issues,
time
the
off
expense,
work, time
exactly,
off childcare,
because they
whatever.
said go it was the same thing with like a sprained ankle, say, well, get checked by your family doctor within the next 3 to 5 days,
and they're just following instructions, right?
Yeah.
So
Yeah,
they're just being good patients.
I actually learned that from you, Rick, about like setting expectations, and don't do this. Stop doing this.
Please
know better.
I think back pain is such a
Pain in the
challenging kind of thing to deal with, and people say, well, if it's done on the job, it's like, well, can I go to PT or those kinds of things? And there's all of these distractions to take care of you while you're healing, kind of thing. Okay. We'll send you to PT 3 times a week, and you rub your back with this naproxen cream and all of these kinds of things that we're trying to help, but we're all just buying time, for this thing to get better.
Yeah.
I may have sounded like I disparaged PT, and I'm going to give
no. We're in the same boat with PT.
Jan's email address coming up to you.
You can give him mine, because
all the stuff you go send to Jan. Okay.
Well, you can give them mine, because there's something to be sitting amongst the rubble with someone, and just having someone, when they go to a physical therapist, or they go to a massage therapist, or and I'm not the two aren't the same, obviously, but the time that they spend with them. Yes. And they're allowed to talk about what's going on and how their life experience and stuff like that. Just being able to sit amongst the rubble with the patient is very therapeutic, and it has nothing to do with the laying of hands.
Well, I think the laying of hands is interpreted as valuable. That's why chiropractic is so popular.
Sure, but
you're out of alignment. Your caster and camber are off here. Your tires are going down the road crooked or something like that.
But they can do sham treatments, and it doesn't make a difference. So it removes the laying of hands. It's the spending of the time and having a caring, empathetic clinician listening to you.
All 30. 30.
Relationship. Yeah, the relationship between pain management modality and return rates for low back pain in the emergency department. And I like this study. We've talked about how challenging the condition of low back pain can be. So ASAP updated their policy on opioids in 2020. There were no level A recommendation. There was one level B recommendation about withdrawal, not about treatment, but about withdrawal from opioids. And then there were a lot of C recommendations, and they didn't address actually treating patients in the ED with opioids, but they did ask about using opioids at discharge. So sending people home and saying, if you have to, okay, and use the smallest amount possible for the shortest duration. But these authors wanted to know, listen, if you gave someone an opioid in the ED for their painful condition and compared that with acetaminophen, NSAIDs, or Jan, your combo of both, right? And said, what was the return rate to the emergency department for the same diagnosis, same diagnostic code, is how they pulled these out. And so it was a retrospective study, multi-center, observational, done in the US. More than a third of patients got opioids in the ED, and about a quarter returned within 30 days. And then they compared it to if they got NSAIDs or acetaminophen of the combo. And the actual odds ratio was 1.78. So that means 32% increase in return visits if you were given an opioid. And so actually, I wrote this in my notes before we had recorded the first session and stuff, where Jan said, if you build it, they will come. This is the field of dreams. If you give them opioids in the emergency department, they're more likely to return to the emergency department. And so opioid use in the emergency department, because it's a retrospective study, is associated with a higher likelihood of returning within 30 days for the same problem compared to other analgesics.
But couldn't it be that just their back pain was a lot worse, and so they got the stronger medicine, the opioid, and so maybe they come back because they have, worse pathology or worse pain. I don't know that I believe that. I'm just throwing it out as like
no. That's why
if it's observational. Yeah,
you're absolutely right, and that's why we use the term associated. And there can always be both measured and unmeasured confounders, and you try to control for this with adjusted, and you try to compare apples to apples. And some studies will do propensity score matching and stuff. So this is just an association. And that's why I said it's associated with a more likely return for the same condition.
Yeah, because I'm trying not to be too cynical about it. There's the like, don't feed the bears, don't give them the opiates because they'll just come back for it. Again, sort of cynical view of it. And I'm just trying to step back and be like, well, maybe there's other things that have to do that show this, make this association exist.
Exactly.
You've been great because you've been such a great devil's advocate for all of this. The whole show, it's like it's awesome. Devil's advocate.
The reason you
don't
come back to the ER is because you were given ineffective therapy the first time.
You see, so you could, so you can, physicians are so smart like you, Rick. We can rationalize anything post hoc and say, well, it's because we didn't give them opioids didn't work, so that's why they came back again.
Or I'm centering it on maybe they come back because they did get some relief in the ER, and all of these other patients that got no relief because you gave them all this Tylenol crap and some NSAIDs and.
Maybe they said, "Oh, I'm not going back to that shop. Yeah, they don't even treat pain effectively." Yeah, so
give me some,
at the end of the day, we don't know.
Well, I didn't really know how to interpret this paper, to tell you the truth, and I thought, well, maybe everybody's going to have a different point of view, but it is kind of strange that people who got opioids came back to the ER and the others didn't, and so I want to take the perverse view that says, well, the first group didn't get any treatment anyway. That's why I didn't come back. That I think that would be classified as a little cynical.
All we know is associations from the data we have. If we had a randomized control trial with this, we could have probably teased that question out about what's the return rate.
I wish I'd had, some kind of like hit it out of the park paper for are we up to like number 31?
Yeah.
Yes.
Yeah. It's kind of like a little anticlimactic, but it's another one of those.
I don't think this one's anticlimactic. Well, I like this paper.
It's kind of typical of these papers that say, this is a new treatment. It works. It's fabulous. And so there's this big, hoopla about something. And then this is like the corrections.
And then we did a better study.
It's the clarifications in the newspaper that get printed in the bottom 3 days later. This is TXA for nosebleeds. And I think there was some paper. I know there was a paper that said this stuff works and it prevents this, that, and the other thing. Well, this is a UK study, 26 emergency departments, looking to see if putting TXA in the nose would prevent the necessity for, putting a packing in. And of the 211 patients in the study, 44% got in the TXA group and 41% in the placebo group wind up getting Pacos. So according to this, it really didn't work. There's no difference in any secondary outcome measure, and TXA did not reduce the use of nasal packing, which is kind of like I thought it did. It's like, don't confuse me here with the facts. Ken, rip up this study here, will you? Is there a way you could? It's TXA versus placebo.
Jan's ready to go. I'm going to let her.
No, do it.
Are you sure?
I like the title, No Pack. I was just going to say, I really like the title. No Pack. It's a great title. That was
and that's in the Rick Bukata Advanced School of Title Writing, where you come up with an acronym that says the whole thing. No Pack.
No Pack.
But
I'm not a packer.
Opposite. You're supposed to not be able to pack if you put the TXA in. It didn't work.
Yeah, well, I mean, many of us did get excited. I tend to be skeptical with regards to these types of things, but there was a couple of studies that came out. Both were from the same centers. I believe it was in the Middle East, and one was just on all comers, and then one was on patients with antiplatelet therapy. I think just antiplatelet therapy was their follow-up paper. But there was some key differences here, Rick, and this is, I think, where we can tease out the issues. The two positive trials, right, looked at people coming in. This group of patients who had epistaxis had to have failed to resolve their epistaxis after 10 minutes of direct pressure and 10 minutes of shoving up some packing with topical vasoconstrictors. So these are the people that have failed the conventional therapy, not the people that came in and got TXA put up their nose, right? Like in the other studies. So these were there's some selection bias of, these are people with, bad nosebleeds that aren't responding to typical therapy of, hey, wouldn't you try this first and then put a vasoconstrictor up here? And then they also used a lower dose. They used 200 milligrams instead of 500 milligrams. They could repeat the 200 milligrams on that cotton plagette, but the other studies used 500, and their primary outcomes were different. The primary outcome in those other studies was, did the bleeding stop or not? And had high success rates and high satisfaction rates. This one was, did they need to be packed or not? Yeah. So at the end, it just raises my skepticism. But I was already skeptical to begin with about the efficacy of TXA for epistaxis or almost anything nowadays. But it just raises my skepticism.
Jan?
Yeah, I mean, pressure and a topical vasoconstrictor are very effective in and of themselves. I mean, that's a pretty good therapy. And so, if you don't respond to those, then, it is kind of a different category than what was studied before. So, I think it's our standard approach of trying those things first and doing them correctly and well is probably very effective. And, after that, maybe TXA doesn't make such a big difference, but it's also, I don't know, it's hard to get TXA out of people's hands because they really like it right now. And it's not hard to use. Anecdotally, people feel like it makes a difference, but I did find this paper interesting and thought provoking, and maybe I like to use Rick's term, it kind of kicked it in the shins a little bit. Poor TXA.
But I love it. I love it when I read a paper that challenges, preconceived notions and what you're already doing. And I think we should be, that's the sign of an open-minded skeptic, right? To say, oh, okay, well, let's take a look at that and if it's convincing evidence, change your practice because of it.
We were so ready to believe those other trials when they came out, the ones that, showed that it worked, even though they were small and, there was they use the plagettes, as you say it.
I say plagettes. Is that a French pledget?
What do you call it? Oh, well, this is French, I guess. Plaget.
Plaget.
Yeah. You get but it's like the X-Files, right? You want to believe, right? And science doesn't care what you believe. It cares about, it has no agency, but it's what can be demonstrated.
Well, we only had 2 hours with this, and I think the goal of this was to basically kind of see that the literature really is our friend, and there's so much that we can learn by reviewing it. And I got to tell you that I know that a lot of you are subscribers to MRAP, and there's a segment on there called Emergency Medical Abstracts. you should give it an hour a month, and you'll be, it's just so helpful to try to keep up with this literature. And the only way I know to do it is to listen to those guys on MRAP. Guys, I want to thank you very, very much for participating. Ken, it is now 11:10 where you are, and you have a shift at 8:00 tomorrow morning. And I really appreciate your taking the time to do this with us tonight.
I always get excited to talk about the literature. So we could have been doing this at 3 a.m. and I would have been, sure, let's talk about the literature. Let's talk, let's get into it.
I love it.
And of course to work with, Jan and you, but yeah.
Jan, thanks so much. And give our best to Billy.
I will. He's sorry he couldn't be here. And, we do miss him in our recording here, but he's doing okay. And thanks for having me, Rick.
Bye-bye, guys. Let me tell you, before you sign off here, I want to give you my email address. If you have any comments, questions, disagreements,
is it jan.Shoenberger at
WR Bukata, at gmail.com. I'd love to hear from you, and I'll pass on your comments to Jan and Ken if you want to get to them. So thanks for listening, and we hope to talk to you next year at this time. Bye for now.
Thanks.